Okay, so it's my great pleasure to introduce our last speaker, Dr. Richard Schulz from the Department of Psychiatry and the University Center for Social and Urban Research from the University of Pittsburgh. And I was told I have to give very brief introductions, so I cannot say anything more about Rich, but you'll find all you need to know on this slide and more on this website, of course. So we are very excited to have you here, Rich, and please join me in welcoming Dr. Richard Schulz as our last speaker. Thank you.
Switch you over.
Well, this is the only place where we acknowledge support, so I do want to recognize the various NIH institutes that have supported this research over the last couple of decades, actually. And just take a minute to read this because it really summarizes or captures some of the key elements of what I'm going to be talking about today. The same cartoonist has one of my other favorite cartoons of his is there's a patient in a doctor's office and the doctor says to him, you can exercise 30 minutes a day or you can be dead 24/7. Okay, so I'm going to talk about an applied problem, and I think one of the messages that's going to come through here is that these problems are highly contextual. I think that's something we've sort of put to the side as we look at these mechanisms kinds of studies that have been presented in the last couple of days. And, you know, I was originally trained as a social psychologist, and so being at this meeting was a big delight for me because everybody's thinking at a level that I used to be thinking at a long time ago and would like to get back to. But what I'm going to focus on is sort of looking at an applied problem, a problem of chronic stress exposure that you'll see leads back to some interesting and important questions about emotion regulation and how you might implement it in the real world. Now, I originally got interested in caregiving. I was a social psych stress researcher, trained in laboratory experiments primarily. And this problem came up actually in the late 80s as a kind of context where there's a lot of stress-related things happening and might be very fruitful for studying. And that turned out to be very true as you know, the last 2 decades of thousands of studies in this area have shown. And the reason it's an important area and a great research platform is that, first of all, it is a big social issue. In any given year, there are about 60 million Americans involved in providing care to family members. And from an economic point of view, if you were to pay for, replace those family members as caregivers, you'd have to spend over $300 billion annually. So it's more than we currently spend in the entire long-term care system in the US. Caregiving also has a number of interesting transitions. You can look at increasing, decreasing levels of chronic stress. It has a bereavement transition, so if you want to look at the effects of death, you can do that. Institutionalization is another phenomenon you can examine in this context, and so on. The level of analysis is, you know, you can go all the way from high-level policy, macro-type analysis, to very micro, and there have been a lot of psychobiological, psychoneuroimmunology type studies that have investigated the stress of caregiving and showing effects at that level, and we'll see some of those in a moment. And there are a lot of theoretical approaches you can bring to bear. Obvious ones being stress coping, interpersonal relationships, helping behavior, altruism, emotion regulation, and so on. So a lot of things that we were exposed to as graduate students play out in this context and provide opportunities for testing in the real world. And of course, you could use any one of multiple methods to pursue these questions. Well, why is it a chronic stressor? Well, it has these 3 standard characteristics. It's persistent, uncontrollable, and unpredictable. It generates physical and psychological strain, and it generates a lot of secondary stress. And let me just back up 1 second and make sure we're all on the same page in terms of what I'm talking about. I'm talking about informal family caregiving, right? Not professional caregiving. Okay. So I want to initially look at some caregiver transitions, and it's important to do this because from a scientific perspective, if you really want to nail down causal relationships between exposure and impact, you need to follow people as they move through into and out of the caregiving role. And we'll look at a couple of exit transitions, including bereavement and placement. We'll look at some of the treatment implications. And I want to end up and talk considerably about caregiving and emotion regulation. What kind of opportunities are there and challenges are there for regulating emotions in that context? And so the first thing is, and just to give you a little bit of background, I mean, this research area has been around for a long time. In the early 90s, there were dozens of studies published showing that caregiving is stressful. Well, from a policy perspective, the response to that was, well, life is stressful. Let's move on to something else. And it wasn't until the question was raised about the translation of stress to physical and psychological adverse outcomes that attention to this area grew and received a lot more attention from a policy, funding, and all those points of view. So our goal, what we started doing in the late 90s was trying to unravel this process longitudinally within person to see what happens to individuals as they move through this caregiving career. And this is sort of a simple rendition of it. And for those of you who aren't familiar with what happens, although I will predict that all of you, if you aren't, will become familiar with this sometime in your life. Typically, it begins with some IADL problems, things like cooking, cleaning, finances, some disability related to chronic illness. Those problems become more problematic, more difficult over time. They typically lapse into problems with bathing, dressing, eating. And if you follow people long enough, one of two things, well, these two things are ultimately likely to happen. Either the person is placed and then dies, or as is often the case, the person dies in your home while you're taking care of them. So that's the trajectory we want to follow. And there are a lot of interesting questions you can ask along the way. What's the psychological appraisal? How do you respond to this psychologically as you move through these stages? What are the health effects? And finally, what can you do about it? How can you help people as they move through these various states?
I have a quick question.
Sure.
This seems to presume that the person you're caregiving for is a parent. It could be a sibling or a child who has a disability, in which case you might not see the same pattern of expanded ADL over time.
Good point. Yeah, my bias is toward caregiving in late life. So yeah, we're looking at adult children caring for parents or spouses, older spouses caring for the husband or wife. There's a whole nother area of caregiving for children with chronic illness, for or caregiving in midlife with other with mental health problems.
Right.
And yeah, this applies primarily to the late, although this is the dominant kind of caregiving that occurs in the United States. About 75% of all caregiving occurs in this age range.
Thanks.
Okay, so let's look at some of these transitions very quickly. The transition into the caregiving role, and I'll tell you a study we started in the 90s. This was part of a large epidemiologic study of the elderly that we were involved with. That's actually still ongoing. We followed a cohort of roughly 6,000 people who were all 65 and older at the time. And the idea is that they'll be followed until they die. And at this point, most of them have died. So we were primarily interested in looking at cardiovascular risk in old age. But this gave us an opportunity to carve out a sample of 800 married dyads. And these people were recruited from 4 areas around the US. So we have 400 dyads, and we selected them so that we had 800 dyads. 400 were clean with respect to illness and disability. They had no major chronic illness or disability. And the other half, one member of the dyad had to have a disability. So we're starting out with some variability in the presence or absence of disability in the dyad, and we're going to follow them. We're still following them for 20 years or so. And of course, what's going to happen is disability will emerge, and we're going to be able to see the health effects of that emergent disability. People will die, disabilities will get worse, and so on. So all the phenomena, all those transitions that we're interested in are going to take place, and we'll be able to look at people as they move into these states. And so here's an example of moving into a caregiving state. Here we're looking at depressive symptoms pre and post transition, and we're looking at 2 types of transition. One is, we call this moderate caregiving, and the other is heavy caregiving, and roughly they're equivalent to moving into an IADL caregiving role where you're helping out with a few small things, and heavy-duty caregiving is pretty intense stuff. You're working with someone with profound levels of disability. And what you see here in these 2 transition states is that the action is at the heavy caregiving role. You get dramatic increases in depressive symptomatology as people move from the non-heavy to heavy caregiving in this particular example. We also looked at self-reported health, and again, it's that heavy caregiving role that causes you to report poor health. We also look at health risk behaviors as a possible mediator. What are people doing? How well are they taking care of themselves, seeing a doctor when they need to, and so on. And so this is a negative indicator. The higher the bar, the worse you are at doing this. And here again, you see this heavy caregiving effect. It's moving into that mid-intense stage of caregiving that exacts a price with respect to the health of the individual. Another way of looking at this, we bring people into the clinic annually and do look at for prevalent disease and new incident disease. You see 3 groups illustrated here: non-caregivers, moderate, and heavy-duty caregivers. And what you note is that heavy caregivers start out being sicker to begin with, and they get worse faster. So there is this acceleration of negative health effects. Yes?
Sorry, I have a similar clarifying question, which is, are the caregivers necessarily the spouse that's in the dyad, or anybody else that's a child?
It's going to vary. In this particular example, these are spouses. They're older spouses. Everyone's over the age of 65. But we'll see some other data where we're looking at adult children, sometimes adult children combined with spouses. So, okay. But I'll try to keep that.
So in these 800 dyads, you have.
These are all old. These are now all older married couples, all over the age of 65.
In which case, it's the caregiver is one of the 2 spouses.
Exactly.
Okay. Thanks.
And finally, we did a study we published in 1999 where we looked at risk factors for mortality and then controlling for all of the traditional risks. We see that being a strained caregiver increases the risk of mortality. This is over about a 5-year period by about 63%. So, fairly compelling evidence that we ought to take seriously the health consequences of being cast in this role over a relatively long period of time. So if we go back to that figure we had earlier, you begin to fill in the picture, and you see that all those negative effects appear in that middle stage of a caregiver's career, and that's parenthetically also where most intervention studies, as we'll see, they try to target that phase of the caregiver's life. At the front end, the effects that are relatively benign from a psychological point of view, and there isn't a lot of evidence that you get negative health effects in the early stages of a caregiving career. In fact, there are people, at least from a self-report perspective, are able to articulate a lot of positives about playing this role for a relative that they're close to. So what about the death of the care recipient? Now, when I was in graduate school, we used to use the Holmes and Ray stressful life event scale. You remember that? And the top item was death of your spouse as the most stressful thing you could experience. Well, this work has shed new light on that, and it tells us again that even something like death is highly contextual. So here we're looking at pre-death and post-death, and we're looking at three groups again: non-caregivers, non-strained caregivers, and caregivers who are reporting strain, which is the red line on top. And as you would expect, prior to death, strained caregivers are a lot more depressed than the other two groups. But interestingly, there's no evidence that they show increases in depressive symptomatology as a result of the death of the person they were caring for. Brian?
Just a clarifying question.
Yeah.
When you define strain here, when you define strain here, is it subjectively or objectively
It's totally
described?
Subjective. It's their saying, I'm strained.
Thank you.
In this context. It correlates with how much they're doing for the person and so on, but it's a self-report. On the other hand, you get a kind of a dose-response. I mean, another way to look at these data is there's kind of a dose-response relationship between prior exposure to caregiving and the effect of death on the individual. So if you've had, if you're a non-caregiver, there's a big jump in depressive symptoms. If you're a caregiver but not strained, you say it's not a big deal for me, you get a moderate increase in depressive symptomatology. So in a perverse way now, caregiving begins to look protective with respect to the effects of bereavement on the individual, and we can speculate about why that might be. So we collected other kinds of data. This is looking at weight loss, and this is an elderly sample, so this is a risk factor for mortality. Weight loss is bad, and it's only the non-caregivers that show significant weight loss after the death of their spouse. You can also look at antidepressant medication use, and it's only the non-caregivers that show a significant increase. And finally, and this is a different sample, it's looking exclusively at Alzheimer's caregivers. The 0 point here is the point of death, and we're modeling depressive symptoms over time, and this is over an 80-week period roughly, and we're looking at what happens to those symptoms. And when this first came out, there was a lot of debate about people not believing the data. There is this spike right at the point at which the death occurs, but remarkable recovery, so that these people are down to normative levels of depressive symptomatology by about 20, 30 weeks after the death of a person with Alzheimer's disease that they have been caring for. And if you ask them questions about whether they were prepared for the care recipient's death, whether it was relief to the caregiver and a relief to the care recipient, you see that they're willing to say something which on the face of it is pretty socially unacceptable. That is that the death was a relief to them. 27% are willing to say that this death was a relief to me, and say that this is true very much, and 44% say somewhat, and of course, it's an even greater relief to the patient from their point of view. So that's the bereavement transition, and I think it makes the important point that bereavement is contextual, and in this context, it's not necessarily such a bad thing. And the other transition we want to look at, for reasons that will, I think, become clearer later, but we want to understand what happens to the placement to the caregiver when the person is placed in a long-term care facility permanently. And here, from a stress exposure point of view, one of the things that's going to change when you institutionalized is the pragmatics of care provision. You don't have the day-to-day challenges of providing or supporting that individual. And you want to ask the question, well, does removing that responsibility have a significant impact on how you do? And as you can see here, this is depression and anxiety, basically no effect. The 0 point here is the point of institutionalization, and we're following them for a couple of years, and there's really no evidence of any kind of recovery like we saw with the death data earlier. In a study, we're just now finishing a randomized trial, and this is descriptive data. And again, the baseline is just shortly before institutionalization, and again, no evidence that there's recovery or improvement as a result of placing a person in a long-term care facility. So we can put all of this together and get a kind of a fairly complete picture that there's a lot of distress that continues through placement and relief and recovery post-death. Okay, so we understand some of the effects of caregiving. Then, of course, the obvious, that last line we haven't addressed yet in the model I presented earlier. What can you do about it? Well, we started a large randomized trial that took about 12 years to finish. It was played out in 2 phases. One was sort of a development phase, and this was a multi-site trial involving multiple universities throughout the US, and we had to do this just to generate the sample sizes we needed. In the first phase, we recruited 1,200 and some dementia caregivers and their patients, and in the second phase, it was a smaller number to actually implement a unified randomized trial. In the first phase, which I'm not going to talk about a lot, was all about testing lots of different strategies for improving the health of caregivers. And then the second phase was designing a traditional randomized clinical trial where all sites implement the same intervention under fairly strict oversight of the coordinating center, which I had the pleasure of leading. Just to give you a quick picture of what that the REACH-2 design was, it was a randomized clinical trial, 1 active treatment and a control condition. There were 5 sites, including Palo Alto, and we recruited equal numbers of African Americans, whites, and Hispanics, and one of the requirements of the trial was that we had to test essentially the intervention in each of those 3 ethnic racial groups. So we had about 200 in each of those groups, 100 assigned to treatment, 100 to control. And so the design looks something like this. You get recruitment, screening, baseline assessment, randomization, and then a 6-month follow-up, and the study was carried out within that 6-month interval. Now, I'm not going to say a lot about what exactly we did for people, but I think it's important to appreciate the complexity of these real-life problems and how there is no silver bullet solution to them. I mean, unlike, for example, some psychiatric diagnoses where people have depression and you have a depression treatment strategy you implement and so on. What these people have are lots of related problems at varying levels of intensity. And so it requires a treatment strategy that's fairly adaptive with respect to individual variability and need. And so we do this risk appraisal, and it assesses risk in about half a dozen areas, which I'll show you. The intervention has fixed components. It addresses a fixed number of domains, but the dosing within each domain is adjusted to your risk profile. So there's some tailoring there. And then there's an outcome assessment strategy that's linked to the intervention, as you would expect. And the risk appraisal and intervention looked at these issues, burden, problem areas, problem behaviors of the dementia patient, social support, social integration, self-care, physical health, emotional well-being, and for everybody we had to address issues of safety like access to weapons and driving and so on. So people received a dosing based on their risk appraisal in these domains, and this was delivered over a 6-month period in 12 to 14 sessions lasting minimally an hour each. And what we find is, I'm going to show you one outcome summary. This is clinically significant net improvement. And this is actually a non-parametric kind of analysis of these data. And it's looking at the combined impact of the intervention on all of these areas that are listed there and comparing treatment with control by race. And what you see is there are big effects everywhere, but they're especially large for Hispanics, and we think that's a sort of a relative deprivation kind of impact. And the intervention was delivered for them in Spanish, so they're getting something that they had relatively little access to, I think, compared to the other groups that were in the study. And when we published the outcomes data for this particular intervention study, we did get some nice endorsement with in an editorial that was published along with the major outcomes data for that. And actually, these guys, I think, are at UCSF, so I'll have to look them up sometime. Thank them. Okay, so I think we had some moderate to good success with respect to impacting the lives of these dementia caregivers. But it didn't really, we certainly didn't solve all their problems. There was a lot of residual negative affect, negative health effects in physical domains and so on. So I started at this point thinking about what's missing here. And to answer that question, you had to think about what we knew with respect to what causes stress in this context and try to identify what's not on the list. And here's the thing I came up with at the time. So listed above are all these ADL, IADL disability problems that are typically identified as the things that make caregiving stressful. You have the disability, you have memory problems, you have problem behaviors, there's high vigilance demands, there's a lot of work and frustration of care provision, there are a lot of secondary stressors, and so on. And then we started, the thing I started dwelling on, maybe obsessing about, was this issue of suffering. But one of the things that characterizes this situation, aside from all the things that are going on in white here, is that you're exposed to the suffering of another human being 24/7. And the question is, does the mere exposure have some impact on the health and well-being of the caregiver? And that's the kind of question we began pursuing, and we organized a small group at Pitt to, mostly made up of palliative care physicians who have always been interested in suffering, but trying to define what is suffering and how is it different than all of these other things. And you know, the kinds of distinctions you come up with are illustrated here. You know, it's not the same as illness and the work of care, clearly, because people can have equivalent levels of illness and show vastly different levels of suffering. It hasn't really received a lot of attention in the empirical literature. It could be a primary source of stress, and if you're right, it would lead you to think about new ways that in which you might intervene for this kind of chronic stress exposure. And so once we saw that or thought about that, we started reanalyzing some of our old data. So we did one study where we went back and looked at depression burden in caregivers of AD patients using some of the same data I used earlier. And what you basically tried to do, and thankfully I didn't try to plot any regression lines, but these are, these are essentially multivariate regression models where you show sort of controlling for everything that you know is associated with caregiving is suffering an independent predictor of caregiver outcome, and it turns out it is. We also looked at depression, cardiovascular disease in older adult spouses. So we're looking, and we do this prospectively. So we're looking at at incident depression and cardiovascular disease as a function of how much your partner is suffering, controlling for lots of other stuff. And indeed, you find a fairly strong relationship. The other puzzling thing, there are these reports in the literature where you have two children who are caring for, or who have a parent who is ill and disabled. One of the children is involved in care provision. The other is not, but they're just as depressed. So again, that sort of points, there's something else going on here. And finally, the data I showed you earlier about death and institutionalization, there are a lot of differences between those states, obviously, but a big one is that when somebody dies, their suffering ends, whereas when they're institutionalized, their suffering continues, at least in your mind. And parenthetically, along with some of those, consistent with those data, the more you visit your relative in a long-term care institution, the worse off you are. Okay. So we began to rethink the model of caregiving, and those lines above are, the boxes above are the traditional model. You have, these are the factors that drive, they're sources of, considered to be sources of stress. They're traditional factors. They have impacts on emotional, behavioral, physical responses. There may be secondary stressors that get activated, and that's why you get these negative impacts. So we added to that now a suffering link. So you have this separate piece where you're looking at patient suffering, which is in part generated by these factors, and the caregiver's appraisal of that suffering, which now adds some, the argument is some unique variance, contributes unique variance with respect to these outcomes. So why might that be? Well, the kinds of things you have operating are things like cognitive empathy, mimicry and feedback, conditioned responding in the caregiver. All of these factors would come into play with respect to being exposed to these conditions and having them ultimately lead to this outcome. And the intermediate states could be a variety of caregiver emotions which might be similar, complementary, or defensive. You can imagine a variety of different scenarios that a exposure to suffering might generate. And so then we did a study, went back to the lab, and this is like 30 years after I left the lab. So Joan Monin and I did a study with the help of Dick Jennings and other people at Pitt who are knowledgeable about doing reactivity studies. So we brought couples to the lab, older married couples, one of whom had to have osteoarthritis. And roughly, you see their characteristics described here. And what we wanted to do is get a lot of background data, of course, and we want to create a situation where they would watch the care recipient perform a pain-eliciting task, hence the choice for people with osteoarthritis, versus watching a stranger. So that's a condition. This was our operationalization of exposing a spouse to the suffering of their partner. And we also wanted them to give a speech about their partner suffering versus giving a speech about a typical meal with their partner as a control condition. And so the pain eliciting task is one, it's been used by others in the literature, and this was a little tricky getting past IRB issues, but this finally worked. And basically what it involves is the person has to bend over, put those logs in the carrier, carry them to another location, unload them, and go this back and forth several times, and we're filming them with video cameras while they're doing this. And here's one of our best subjects. He provided all the data. No. then the caregiver would watch this video as well as be exposed to other stimuli, and we'd do heart rate and blood pressure while they're doing these tasks. So the design is a baseline. There's habituation. You make a spouse perform the pain-eliciting task, and you watch the stranger perform a pain-eliciting task, and they're equated for level of suffering that is emitted in the two tapes. You think about a time when the spouse was suffering, think and talk about, and a time when you're doing a typical meal and spouse, and it's all counterbalanced to eliminate order effects. And so what do you find? Well, this is looking at systolic blood pressure, and you do get differences between baseline, stranger, and spouse, and these effects more or less repeat themselves. This is looking at diastolic blood pressure. More arousal when you're watching your spouse suffer as opposed to watching a stranger suffer. And looking at mean heart rate, greater arousal for the stranger and spouse compared to habituation. And this is looking at systolic blood pressure. Again, greater arousal or greater response talking about their partner's suffering than thinking about or talking about a meal. And there's also a lot of self-report data. You can ask them about the level of distress or sympathy they felt, and as you would expect, it's stronger for the spouse than it is for the stranger, and it's stronger for suffering when you're thinking and talking about suffering versus thinking and talking about a meal with your partner. More recently, Joan just finished doing some sort of linguistic markers of emotion regulation analysis of the speeches that people gave when talking about suffering and talking about having a meal with their spouse. And we use this strategy that's been advocated by Pennebaker, but I've learned since coming here it's probably not a good way to do it. And we may redo this. And so we're looking at basically analyzing these speeches they gave for positive emotions and cognitive processing. Those are the two areas where people have made predictions. And the predictions are that positive emotion words should lead to lower reactivity, and cognitive processing words should also lead to lower reactivity in the suffering account. No predictions for negative emotion words, and this is the kind of output that gets generated by the program in terms of types of words and their frequency. And you do get support for those predictions. Positive emotions, lower heart rate reactivity, and more cognitive processing leads to lower blood pressure reactivity in this case. So this is all suggestive, but it begs the question, how do you pursue emotion regulation strategies in this context? And let me add this. One of the strategies, and this is one that was developed by Gross, who's talked about various strategies that people might use, and this is an example of the kinds of things that might be done to help regulate emotions in this context. And this is something we haven't done yet, but I think would be interesting to pursue and might be fruitful with respect to sort of adding new armament to the ways in which you might help caregivers deal with the challenges they face. And if you look more closely at what has been done or is being done with respect to interventions for caregivers and how they fall within these various emotion regulation strategies, some examples are provided here. So with respect to situation selection, you might try things like giving the caregiver respite or shared caregiving. Institutional placement, it turns out, doesn't really do a lot of work, although one could argue that's a situation selection strategy. You could select settings and activities that are less likely to elicit suffering in the patient, and maybe caregivers do this spontaneously, but it's likely that you could enhance a person's ability to do that. You could modify the situation, reduce the experience of suffering in the patient by providing hospice care, for example. Their whole strategy is aimed at achieving that. Reducing the expression of suffering in patient. And one of the things I've always advocated, and we did test out in a spinal cord injury study, is that when we do these studies, we really ought to intervene with not only the caregiver, but the patient, and teach the patient how to be a better patient. I mean, the patient can do a lot in terms of providing reinforcement and goodies for the caregiver that I think are potentially very beneficial. Probably hard to do, but worth looking into. And one of the things specifically, I mean, a patient who's accurately able to reinforce support behaviors, I think, is likely to be much more appreciated and make the caregiving task much easier. Attentional deployment, people have tried things like engaging in pleasant events, focus on positive aspects of life. There are probably other strategies one could invoke that would fit under that rubric. And finally, there's a whole host of cognitive reappraisal strategies that could be applied, and I think one of them that's becoming, sort of emerging as a promising one, is this whole issue of mindfulness training that might be used with caregivers. And what's interesting about, if you think about the caregiving career as you move through this situation, you have a circumstance where I think, and this is sort of, I don't have very concrete data to support this. I think what happens is early on, you get a lot of highs from being a caregiver. You're really making a difference in another person's life in a very meaningful way, because you're able to address suffering issues, have an impact. It's when you move down that stream and eventually, and often this is the case, you hit a brick wall where no matter what you do or no matter what you can do, there's nothing you can do to change the suffering of that person. And that's where it gets really tough. And that might, from a research point of view, looking at people in that circumstance might be very interesting with respect to how they try to regulate emotions and what might be done to help them regulate emotions. So that's, I think, something that's potentially very fruitful. So a couple of concluding comments. So we've seen that there are a lot of adverse psychological and physical health effects that you can point to. You can be moderately successful with existing intervention strategies. Exposure to suffering may be a unique source of distress for caregivers and contribute to these health effects. And we can think about ways in which how to regulate emotions under extreme conditions, and finding solutions to that question, I think, would be a very important contribution, not only from an implied perspective, but I think possibly also from a theoretical point of view. So thank you. Brian.
This may not be the solution you're looking for, but I was thinking about how do you regulate emotions in a person who may not have very much regulatory capacity, especially somebody with, say, Alzheimer's or something like that. Mm-hmm. And you may have data that can address this, actually. So one solution would be to put them on antidepressants or something like that if they were suffering a lot of distress. And the reason I think that might be interesting to look at is because you could actually measure the depression of their caregiver. And so look at secondhand effects of antidepressants. You may have it in your data already. I don't know. Yeah,
that's been done.
Oh, that's been done. Okay. And does it work?
Yeah, your prediction is right on. It's,
my God! Wow.
If you first time today. Yeah, there are studies where, and for me, they're perfectly consistent with the suffering perspective, where you treat the depression in the AD patient by giving them medications, and you don't change any of the care demands. I mean, it's just as demanding to care for that person who wasn't depressed from the caregiver's point of view. but the caregiver feels much better about it. So, yes?
So I have two questions. The first is just a clarification, and excuse me if you said this at the outset. So how much time are the caregivers devoting to caring for these individuals, and does that relate to the results that you see?
Yes, I mean, that's a good proxy measure for the intensity or demands. And in most of these studies, you're looking at minimally 20 hours a week. And in many cases, it's, you know, if you're counting vigilance activities, you know, having to watch, it's almost 24/7.
So if there's someone who has a career, they have a family of their own, you know, they're an adult caring for an aging parent, spending an additional 20 hours plus on this, of course, can be very stressful. So it leads me to ask, what about individuals whose you know, sole job it is to say, instead of this kind of caregiver, they're a paid person who comes in and provides home health aid assistance. So do they show the same kinds of effects where this is their chosen career and they're doing this? It's not their family members, so there's a bit of psychological distance incurred as a function of that. Do they show these same kinds of adverse effects?
Good, yeah, that's a great question, and one I've pondered over as well. I don't know of any data that shows that. There's some indirect evidence. So for example, if you look at nurses' aides in nursing homes, to me, they're like, you know, they're in the front lines of 8 hours a day of suffering exposure, right? And the confounding variable is that they get low pay. But one of the big problems with nurses' aides is huge turnover rates. It's a job that people do not stay in very long. Now, there's a wage-related alternative explanation that you could argue, but I would say one of the features of this is that it's tough taking on that kind of a job. And one of the things, I work quite a bit with palliative care physicians, and I always ask them, well, you know, how'd you get into this, or what is it that enabled, you know, they deal with basically lots of end-of-life issues dealing with families and patients, and but I never get any good answers other than sort of things like, well, when I was in medical school, I took care of this older woman, and she was dying, and I really got a lot out of that experience, which suggests to me there's some sort of self-selection going on that causes these individuals to end up in that specialty. But beyond that, you don't know. I also always ask them, well, do they give you special training on how to handle these situations? And the answer is generally no, they don't. So, yes?
So I was really interested in the REACH trial.
Mm-hmm.
Information about what they should be doing, or was it actually helping them do things?
Sort of all of the above, depending on the domain. So to be more concrete, if the component of the intervention that dealt with self-care, for example, involved giving them a health passport where they kept records of health appointments they were supposed to follow up on, checkups they were supposed to get. So we're helping them manage accessing necessary care when needed. Depression, the depression component involved things like pleasant events training, teaching them how to take breaks and so rejuvenate themselves. So each of the domains had a specific strategy associated, some of which involved delivering information and knowledge and so on. The general picture that you get out of this strategy overall is that more is better. The more you do, the more time you spend, the better they're going to do. The other element is that passive information conferral, and I think you've seen this in the behavior change literature forever, doesn't work very well. You really have to engage them at a level where they show you they can do something that you want them to do. So that was an important. That's one of the things we learned in REACH 1, that this passive stuff is not good, that you had to engage them, get demonstration. We also thought in REACH 1 that we could teach them rudimentary problem-solving skills. We would teach them how to decompose one problem. They would generalize to others, other problem behaviors of the patient, for example, and didn't work at all. There was no generalized acquisition of problem-solving skills, at least at the level we tried.
There's a question back here.
I think this work is so important. And the last question, of how do you regulate emotions under extreme or futile conditions? Mm-hmm. And we then went to the question of paid nursing or skilled nursing caregivers, and then you mentioned physicians and palliative care physicians. There's actually a lot of work on clinical empathy and skillful. First of all, right now, palliative care fellows now get very specific training. And I just want to mention, because the audience might not know, but the lowest area of burnout in all of medicine is in palliative care teams in oncology. And that's because of the skills and the way they work together. I mean, my career has been working on clinical empathy, and I think that it's very different to be an informal spouse or caregiver. I mean, I think there's so much stress in related to the suffering and witnessing the suffering, but it would be worth looking at if any of those skills could be helpful in that setting, because there's a big difference, and Jean Decidi's work is very relevant here, but on empathy between the brain pathways stuff. Everyone here is very interested in MRIs, but there's very different between sympathetic over-arousal and the kind of pathways involved in that, and pathways that are involved in cognitive empathy. So that I would actually suggest that unless you've seen something specific, because it was in one of your charts, I'd suggest that really good skills in cognitive empathy could actually be preservative, as opposed to make you more vulnerable. But I know it's very different in that domain.
That sounds good. I'll have to talk to you about the training of palliative care physicians and what. Yeah, it would be interesting if they do have a good training program. I think it would be useful to ask the question whether that could be used in a family context. Yes.
I have two somewhat related questions, and the first is about sort of threshold effects to suffering. So in the same way that if you watch a violent movie a million times, you stop. Yeah. I'm just wondering if that's something you've thought about, or if others have taken a look at that sort of thing. My second question is with regards to the difference between spousal caregiving and then child caregiving. And it would seem like there could at least be an argument that while it may be more stressful to be a child caregiver for an older parent, because you might have work demands and family demands, there may also be a sort of respite to the suffering, because you can then go home to your own family and things, or you can, go to work and forget, or these types of things. And versus a spouse where not only maybe are you sort of with it longer, but it's also a lot closer to home in the sense that could be your experience in, soon. Sort of thing.
You're absolutely right. Your last analysis is right on the money. The spouses do have adult children do sort of have an escape clause. I mean, they have the opportunity to sometimes at least remove themselves from the situation and would benefit from that. And so one of the paradoxes is, for example, working caregivers aren't necessarily worse off than non-working adult children caregivers, and the thinking is that there are that work is in a sense a respite opportunity that's beneficial to them. As to threshold effects, I don't know of any, and it's a very interesting question. If you get this 24/7 exposure over very long periods of time, is there any kind of adaptation? Indirect evidence would suggest that, you do see instances that over time you get more negative behavior toward the care recipient, potentially abusive type behavior. I mean, those things emerge with long-term exposure to a patient whom you have to care for, but it's not a common phenomenon. For the most part, you see this continued and intransigent distress in the caregiver, and there is really no adaptation to what's going on. Yeah.
I think it was Philip Roth wrote the book about taking care of his father, and I may be wrong about the author, but it's a really moving story of how his guy who terrorized him when he was young, you know, and created all of his characteristic neuroses in late life, became increasingly helpless. And if you haven't read it, it's a really great story. Not inspiring, but interesting about the psychology. Anyway, I was thinking that one of the things that's interesting about caregiving in late life is that, in a way, the care receiver becomes more and more infantile and helpless, and so in a way, it's kind of like superficially caring for a newborn, and it kind of goes. It's kind of finished as that circle.
You don't want to say that in a caregiving meeting.
Yeah. Okay. Well, that was what I was going to ask you about. I was going to say, are the stresses that like young moms and dads experience, and the kinds of psychological and physical problems that they have, they don't seem to be of this quite the same intensity. And what is it about late life caregiving that?
Well, I think one of the key distinguishing features is where is this going? With an infant, it's going all in a positive direction, and here there is no payoff at the end of the service, other than the death of the person you're caring for. And the other payoff is, can you minimize the suffering of the person as he gets there? But
actually, this is going to sound awful, but your data convinced me that there is a payoff at the end, that the death really is a release from suffering, and and I wonder if you could reframe this in that way. It's not the way we think about it, but just like the child will eventually sleep through the night, this person will eventually be relieved from their suffering. Yeah, and why don't we do that?
Well, I think that raises lots of general, huge issues about how we handle end of life in the U.S. and most of the Western world. And the options and strategies that we have out there aren't really appropriate for what is needed. And this strategy could be something that might be entertained. But my own personal view is that we don't have enough personal exit strategies for ourselves or for the people who are close to us. And one of the things that society needs to figure out is giving people more options to leave this world. And that's something that would have profound economic consequences as well, I think, and maybe one road out of the economic mess we're in. Is this being recorded?
Yes. Let me ask a more lighthearted question.
Oh.
Have you looked at personality differences? Because in the sort of empathy personality literature, there's this important distinction between perspective taking, which is really more like the cognitive domain that you were mentioning, that separates the individual. I mean, from the a person for whom we are caregiving, and on the other hand, what's often called empathic distress, which is essentially being flooded by all the terrible stuff that the other person is feeling and not having that separation. And so I'm just curious whether, there may be some people that need extra help, whereas others, may not be suffering as much for these built-in personality reasons.
In the last, in the study with the osteoarthritis patients, we did collect empathy data, and it amplifies the effect. It makes it worse if you're highly empathic. Other things that make it worse is the quality of the relationship. If you have a high-quality relationship, also makes it worse.
So I was thinking that maybe we could use this as an opportunity to ask a question that sort of goes back to the overarching theme of this conference. And so I want to sort of set up a possibility that there really is a perfect storm here of trouble, a brewing. And the perfect storm consists of the following facts, that both adolescence and late life represent a confluence of dangerous weather, Part of it is that they are filled with profound emotions, maybe different kinds of emotions, but strong emotions. They're also filled with decisions that are going to be really important in shaping the directions of lives. And they're also filled with relatively weak frontal lobes. In the case of adolescents, ones that are not fully developed, and in the case of late life, ones that are starting to fray on the edges. So I was thinking of asking the three speakers to sort of, if you're willing to accept this sort of perfect storm analogy, what are some of the critical situations that you see in these times of life where powerful emotions and weak frontal lobes might lead to particularly poor decisions? What are some of the real danger points? And then what are some of the things that we could do to maybe improve those kinds of decisions under those circumstances?
What'd you say?
Myra's going to respond.
Sure, I'll give it a go. So the question of decision-making and aging, something I've thought about, and the things that I think are particularly interesting in that domain are the emotional aspects. Because there's a shift to focus more on emotion in aging, how does that change decision-making? And there's a whole literature on the ways that emotion influences decision-making. And in some of the things we've looked at, trying to figure out just in the literature based on real life context where people have looked at medical decisions, real gambles, playing on lottery shows, in TV shows. The interesting thing is that it's not so simple as saying older adults are worse at decision-making. It's really hard to get a very clear age comparison when you're in these real-world contexts. And in the laboratory as well, not all tasks show the same clear linear pattern that Shachar showed in his data. So quite often there aren't age impairments in the quality of decisions that have been used in the lab. And so what does seem to come out most strongly just in looking at what's been done already is that older adults will avoid making decisions, which is an interesting point. And thinking about it from an emotional perspective, it makes sense because there's research on if you're facing a trade-off, say you have to decide which job to take. And, if it's a difficult decision, it involves trade-offs. There's going to be unhappiness either way if it's a difficult decision. And so the research shows that people feel better if they postpone making the decision than in the moment that they make the decision. So sort of putting something off for now feels better. You're leaving your options open, you haven't yet committed to the losses that are incurred whenever you make a difficult decision. And so this is something that can be emotionally protective for right now, but in many contexts, not making a decision right now is a decision in itself. So in the medical context, this is perhaps where it's seen the most. One study looked at hip replacements and was really puzzled as to why these senior citizens they said were perfect candidates for hip replacements weren't doing them. And so then they did this intensive sort of interview process, and they realized these people hadn't made a decision not to have a hip replacement. They just hadn't made a decision yet. And years would pass by, and if you're not making a decision to have a hip replacement, you're not getting a hip replacement is sort of the actual outcome. So there's ways in which emotion can play into just do you even engage with the decision-making context, and do you want to? And there's also age differences in how much people seek out information. Older adults are less likely to seek out information. So all of those sort of things play in, as well as, if you're given a specific trade-off, how effectively are you able to do the trade-off? And in research we were doing, we were looking at just risky gambles people made in the lab where one gamble was taken for real or not, and at the end one gamble would be played out, so it was for real money. we didn't find any differences in how much risk older adults were likely to take on in their gambles. But one thing that changed was how much they were likely to weight certainty. And so the way this played out in our study was that there were some gambles where there were two options that were both had some risk, some probability. But in some gambles, there was a sure thing. So you would either get $5 for sure, or you'd take a gamble where you could get 50% likelihood of $10. And there is, Kahneman and Tversky pointed out, there's this disconnect for certainty where people overweight certainty about something. And older adults overweighted this more. So they were more likely to pick the sure thing, and they were more likely to avoid a sure loss than younger adults were. And when we looked at their reasoning for this, they were more likely to talk about sort of the positive emotions that they might feel. They seem to be really focusing on the emotional aspects, and in particular the positive emotions more. And so their certainty has that sort of emotional quality, because if you're then after a choice asked, the outcomes played out, and you knew that you could have had $5, but you took that risk, you're probably going to feel worse than if you took that sure thing and there was a gamble and you could have won something, but you didn't know for sure whether you could have. So I think that it's really interesting how emotion can play out, not so much in terms of the quality of the decision that's being made, but how people are approaching it, and whether they're even, how they're engaging with it, whether they're even thinking about it in the same way. And we see some age differences that seem related to that component of things. So I'll stop there.
Yeah, I'll just add one small point. I think, having heard a lot of the great research that's been reported here in the last couple of days, one of the things that I think would be important to pursue, given population trends, especially in old age, and the likely emergence of large segments of the population in pre-dementia kinds of conditions, people with MCI or impaired functioning, I think it would be valuable to explore these mechanisms in those populations. I'm assuming that what happens in most of these studies is you select healthy, high-functioning older people. It would be very interesting to see how these mechanisms play out, or how they deteriorate in populations where you have emerging impairment.
So I think that when Bob, Ron, and I started this journey, I didn't think about these two inflection points in life, and I was very skeptical. Now, going back to the economic literature, actually I noticed that there is something there that I always missed. If you drop out of high school, or the unemployment rate on people that are dropping out of high school is 80%. So in some sense, if you drop out of high school, that's it. You'll never find job. By the way, in the 1960s and the 1970s, this was not the case. People that were high school dropouts, their unemployment rate was exactly like in the general population. But now if you drop out of high school, that's it. It's basically the end of your economic life. And I'm sure that people that are deciding to drop out of high school, many of them, they just don't see how devastating this decision is going to be to them. And then we're running through our life, and when we are facing retirement, then again, we are very prone to make catastrophic decisions. So we are sitting on this huge pile of money, either in our home that we accumulated or in our pension, and our life taking a different course. And many people, for example, in the latest real estate disaster, this is exactly what they did. They made very, very bad investments. So I think that we should be very careful in these two very important points of life, definitely with adolescents, but also with people that are in older ages about retirement, because these people have 20, 30 more years to live, and they accumulated all of this money to live from it. So I think we should be, there are macro and microeconomic indications that at these stages we are making very, very bad decisions that will just are irreversible, basically. Now, I think, again, the question of what we should do in order to make people avoid this decision, again, it's why these mistakes are happening. Are there preferences? I know I sound like a broken record. Are there preferences? Are they constraint? Are they information? Are they beliefs? And we really don't know. So just to the point that you touched, that it is true that we basically we separate between risk aversion to loss aversion. But I think it makes absolutely perfect sense for older people to be loss averse because they have something. They have their entire endowment, their retirement. So basically, if I make now an economic mistake, I didn't accumulate enough in my retirement and I have time to recover. But if I'm doing it in my late 60s, it's on a larger amount of money and there is no way to recover. So actually the fact that older people are much more loss averse and they don't want to make this decision, I think it's perfectly rational. It's actually very good. It doesn't make sense to be loss averse when you don't have what to be loss averse about. But when you have, then I think it makes perfect sense. So, again, how we identify these people, I'm sure that some people, let's take the dropping out of high school. Some people will drop out of high school. There is nothing we can do to help them, no matter how much money and energy we'll invest in, that they won't drop or bringing them back on board. But are there people that we are able to keep them so they don't make these devastating decisions? And who are these people? Because I think this policy of behavior change, for example, is very, very costly. And exactly the same when people are retiring. Who are the people that are prone to make these terrible mistakes? And I think it has to do a lot with also with economic policy. So, for example, some marketing techniques in Florida are not allowed in all of these retirement homes because it's clear that you can trick people into buying a vacuum cleaner for $10,000. Okay, so I have one of those. Yes. Yeah.
So Shachar, I think my question is directly related to what you just said. What can we do? And as we were listening to your talks today and yesterday, it seemed like the three of you had kind of diverging and opposing perspectives on whether people can change. So we heard Shachar, you're convinced that people have stable preferences across the lifespan, and that's something you said yesterday. And then we heard in Mara's talk today, and we learned about how stress and emotions can change the type of decisions we make, and how we learn. And we heard from Rich how transitioning into the caregiver role and out of it, how that can change us and affect our lives. So there seems to be, sort of some divergence in your perspective as to whether people can change. And then as psychologists, we are always focusing on the individual, and as people from economics come in from a very different, maybe more contextual point of view. So I'd be curious to hear your view on, if we want to change behavior, do we start with the individual or do we start with the context? So what's the best point of entry?
So let me just say that, as an economist, I believe that we are also, to a certain extent, we can decide where and when to take action. So I will never make decisions about my portfolio after putting my hand in ice water for 3 minutes. I will just definitely avoid it. I'm making decisions on my portfolios when I'm in my best decision-making ability. It might, and it fluctuated during the day. But I will not try to prove a theorem and basically and do myself something that will increase my stress. So I definitely agree that that stress can have an effect on decision making. I will just say that when we are making very important decisions, we'll try to make them when we are not stressful, when we are not under stressed. Now. To be honest, I don't really know. I wish I knew. when to start. But I agree with you that I feel that we have stable preferences, and the most important thing for us is to identify the people that have low quality decision makers. They just don't have good decision making abilities. And of course, there is a question here whether if I don't have good decision making abilities, it's across domains. It will be in the financial domains, in the health domain, in my marriage, on the road. And I believe, although I have very little data to support it, that it is true. It's about solving trade-offs. And some people are very good in solving these trade-offs, and some people are not. And maybe some people that are not good in solving trade-offs, it's because they are more prone to stress, for example. They cannot handle, because I think I agree with you. Stress is about, or trade-offs is about choosing between bad options or options that are not ranked. And it might be that people with low quality, that make low quality decisions, this is the reason why they make low quality decisions. They cannot choose when to make these decisions. So it definitely might be. So what's the reason why some people are good decision makers and some people are bad decision makers? And here I think that is where we converge. I don't know. I really don't know. It's not education. You see some people that are very successful economically. They have very little education. So, they are street smart, we will say. But what makes somebody street smart and successful, I don't really know.
So several things to respond to. I mean, the good decision maker, bad decision maker you keep talking about, I have a really hard time with that. How can we characterize someone as a good decision maker? I don't feel like beyond one task in our field, we yet have a characterization that we would agree upon that we can say this person is a good decision maker. I think it's really, really tough in the field of decision making to come up with that individual difference measure. I don't know, maybe other people would disagree, and I think it's a topic we should talk about. Yeah,
I think it's actually an exciting development, is that two ideas being able to measure consistency or something like it. I mean, that's a standard. Now, you may or may not agree with that. The second thing, though, is to validate with external measures. So to say, okay, now I'm going to look at assets, which actually both of us turn out to be looking at. And, it turns out that many of the things you might think might be correlated with assets aren't, at least in our sample and apparently in your sample too, like sex or race or even education. And other things that you might not think would be related, like consistency or, meeting some consistency criterion in our data are. I think this is really interesting. I know most of us, when we go to get grant funding, think about health outcomes, but I think it also makes sense to think about economic outcomes. And so that could be one way of externally validating some of these measures. It's not the only external measure we want to look at, obviously.
Let's give Rich a chance to weigh in, and then did you want to?
Yeah, very quickly. The other question you asked was, where's the starting point? Is it the individual or the context? And I think it applies to the conversation we just heard here as well. I don't think you can take the individual out of the context. You can't intervene or even study, I think, decision-making by taking the individual out of the context in which they have to make those decisions. So I'm leery of strategies that focus in on an operationalization of decision measurement in a laboratory setting or other setting that doesn't capture some of the complexity and intricacies and the subjective context that defines people's lives. So I think there's a richer way to understand the problem, and that would be an important, useful goal.
Right. I mean, this all reminds me of the debate about risk-seeking tendencies and how, in the literature they tried to come up with a measure of how risk-taking are people, and it turns out you have to do it by domain.
So this is. So let me just. I totally disagree. I just think that you are using the wrong horse. You are basically coming to a car race with a horse, and then the horse is not winning, and you say, you know, it's basically the way that people, I think, especially in psychology, are trying to elicit risk preferences. This is just not the right machine to do it. And I'll just say one more thing, Ron, and then you are next, I guess. Look, I'm thinking very much about my decision-making ability, like my health. You can ask me, is Shachar healthy? And of course, to say whether Shachar healthy, you need gazillions of tests to really know. However, we have very good statistics. You'll take my blood sample, or you'll measure my cholesterol. You will have a good knowledge about my health from regarding very, very different aspects of my health. So the question is, it is true, everything is domain specific, and there are many things, and also from a blood sample, we cannot learn everything. But you know, it does provide us information about many, many health-related issues. So the question, can't we come with a blood test that will tell us something across domains? From listening to you guys, it's basically, I'm thinking it's hopeless. Anything requires its own individual test, and if we change from Monday to Wednesday, it's another test. And I think this is a dead end. We'll continue collecting anecdotal evidence forever, but we'll never be able to see any picture out of it.
Let's throw this open now to two kinds of questions. You can comment on the topic that's on the table, although I don't think it's very controversial, or you might have follow-up questions for some of the speakers. So, Rod.
Well, hi. I think that the first, well, a couple of things. I mean, I think the individual has to be contextualized, as Rich just said, and I think that one thing that's a little bit frustrating for me is that while the research done by the people presented is completely consistent with this, our language for the conference is a little bit problematic because of the word decision-making, and we're not really even sure what, I think people are using that word a lot of different ways, but in terms of at least predicting long-term health behavior and all of that, it isn't, I mean, Mara put this in a good way, but there's so many determinants of people's long-term health behavior, but it's very rarely a specific decision. I mean, the bioethics gets that wrong, but you know, you might have to decide whether to have a certain surgery at a certain moment. But decision-making in this atomistic sense has been so contested by philosophy of mind, behavioral economics, neuroscience. Everybody is pretty much consistently showing that a moment of conscious, explicit decision-making is just as likely to be a rationalization of ongoing behaviors as anything else. So I think that we're just getting, I think for the sake of a conference where we're looking at long-term behavioral change and health behavior, we need to be much more careful for our collaboration in thinking about what this so-called moment of decision-making even is and why we're focusing on that.
I want to come back to the point that Shachar raised that I think is a source of controversy, and I think picks up on themes, a couple of themes that was just mentioned, about this idea that individuals are good decision makers in some broad sense, or they're not, and whether this is all contextualized. And I want to go back to the framework that Bob first started here about adolescence versus old age. And what I can tell you is that I think the majority of people trying to understand decision making in broad ways in adolescence, especially early to mid-adolescence, would say, and Emily's data and some of the other data we talked about yesterday support this, that the capacity to make a rational decision under some conditions, which is pretty intact by the age of 15, to understand that if I drive drunk or have unprotected sex, that bad things are going to happen to me, the capacity to understand that is not a predictor of their behavior in the context with a group of friends driving in the car or being sexually aroused with someone in a situation. And this has been well studied. And so if the behavior we're interested in is the health relevant behavior that gets you HIV or driving and dying or killing other people, then to say someone's a good decision maker in a computer task that may end up increasing their chance of accumulating wealth, it's very relevant to one characterization of an individual's capacity to make decision. But if we're interested in behavior change that is going to impact risk for HIV or killing people on the highway, which is one of the biggest causes of death among young people, and when you think about your daughter driving in the car, then we need to think about the contextualized decision-making that leads to high consequence impact. And I think that it's not just to say it's so complex we can't ever understand it. I think there's ways to constrain the influence of peers, or that you think you're being observed, or your reputation effects interacting with the ability to cognitively think explicit ways about consequences. And I think we can parse that. And I think part of the excitement of coming together from these different perspectives and disciplines is, where are the areas that seem to really have leverage for impacting the trajectories? And I think one of the and you said this in your comment, it's not just you don't decide to drop out of high school necessarily the way that you sit there and you weigh your consequences. You behave in ways that have consequences, and you get kicked out of school for missing 40 days in a row because you've overslept, because you've stayed up till 2 a.m. doing something else. And if we think of these as, the right, angle of a line on a decision, we're not going to understand necessarily the behavioral patterns that lead someone to, quote, decide to drop out of school, which is, as you say, now high-stakes situation. So I think that individual decision-making in context and individual characteristics that make some individuals in some contexts much more prone to what you would call a bad decision and health-relevant consequences of those decisions require us, I think, to think in some of these more complex ways, even if that capacity to weigh quickly, fluidly outcomes and activate quick, efficient decisions is probably an individual characteristic that has great value. It doesn't necessarily tell us a lot about the risk behaviors, at least in adolescence. So.
Ron, just to weigh in on the ice bucket. So if you were going to study decision making in adolescent heterosexual boys, would you like to sort of put them in a situation where they were either surrounded by their peers or seeing nude pictures or something like that?
I think the most important thing is to have heuristic models of how particular aspects of these affective systems and motivational systems and being in a period of development may interact that would lead to maybe some proxies. You don't necessarily need to show nude pictures or have their peers in the room. You could have a model of what is it that tips this evaluative or valuing process in these ways under certain, high arousal situations, or that it could be much more emotion specific, the kind of question you asked before. But I think we need models that allow us to go back and forth between the laboratory and the real world context. And I guess, come back to Emily's talk, I think the kinds of studies she was outlining in terms of the driving, or that other groups are doing as well, I think we need to have models that say these are contexts where a lot of high-risk individuals make a lot of consequential decisions that we can parse into components of how these emotions or aspects of emotions and motivation are influencing the behavior in ways that if we understood it better, we could be better at intervening or preventing those problems. But other
just for a minute to this.
But really,
a minute. So
the last word. Everybody can.
Word.
You can have one sentence.
Last word. So I don't want it to sound like I think that we have a silver bullet and that's it. We can solve all problems. Many of the things that you just said, I will call constraints. So, and of course, as I said, constraints are extremely important, and they affect behavior. And finally, I would say, what you are basically saying is an empirical question. So, now we are running exactly the same experiments and correlating with driving behavior of a very large insurance companies in Norway, which, they actually share, insurance companies share your driving record. So I see your entire driving record, and I actually see your behavior in this task. And I actually do believe that maybe it's not one-to-one relationships, but a relationship between risk, or it's not actually risk aversion, it's your ability to solve risk trade-offs in the financial domain should be correlated with your ability to solve risk trade-offs in a driving domain, in other domains. Not perfectly, of course. Nothing is correlated perfectly.
Just wanted to say, if you have one thing to say, I would just comment on the preferences being fixed, that the world changes. And so you need to be able to adapt to changing contingencies. A strategy that might have been preferred, might have been good, might no longer yield the outcomes that you want. And so that's something important to consider too, in addition to the individual, is how they're reacting to change that's happening in the world and how it can yield behavior change.
I agree with Ron.
All right. Okay, we're gonna be having lunch shortly, and I have some housekeeping. First thing is we're gonna have you fill out some conference evaluations, and you know, one of the things that we went back and forth when we were planning this thing is how to use the time. You know, there's just not enough time, and so we sort of invested a certain amount in the speakers' presentations, a certain amount in the panels, a certain amount in questions and answers. We have another conference coming up about 11 months from now. It would be really nice to get your feedback. If you have any thought about tweaks and how did this balance work, I think we have about the same number of speakers lined up. So please fill out the evaluations and give us your wisdom as to what could have made this better. We're going to be arranging chairs during lunch, so please take your stuff with you. After lunch, we're going to get together for a brainstorming section, which is really critical to us. It's where do we go from here, you know, and where do we go from here intellectually in terms of the questions that are important, and also practically, like how do we actually catalyze these kinds of multidisciplinary efforts. And we want to invite you, those of you who are Berkeleyans, or those of you who could be Berkeleyans for a few days. Our next conference is going to be held in Berkeley October 10th and 11th, 2013. Again, on this general topic, with more of a focus on applied research. So please come. And all right, so you're doing your evaluations. And then some thank yous, because there's some people we may not see after lunch. So we want to start by thanking Elizabeth. Thank you. At IPSR, we call her the happiness consultant, and I think those of you who had to deal with her would understand why we do that, but she is a great resource and a gift to us, and to you too. And then we want to thank our ninjas. You cannot see them. They move quickly. They only come out at night. They feast on human blood. Oh, no, those are vampires. Sorry. It must be that new Twilight movie about to open up. But if you guys would all stand, Tim and Sandy and Luma and Scott and Anna and Deepak and Michaela, and Alice. Sorry, Michael. Yeah, thank you. So they're really great. I really appreciate all your efforts to make this a good conference. Anything else? And then, Ron, would you like to say something quickly about this upcoming conference?
Just very quickly, this is a conference that's not directly linked to the behavior change, but it is linked as a group that we get across the different organizations units, Institute of Development, IPSR, and the Center for Child Health and Youth Policy, are convening a group to think about, if you think decision-making is hard, think about intrinsic motivations and whether these actually can be influenced by social experience. And we're going to bring together an interesting group of people to consider this as a way that could have enduring effects on behavior and decision-making. And we think particularly during periods of early development and in adolescence, these could be key times, but also other periods of the lifespan. So just to highlight that coming up in a matter of weeks, we're going to have, starting in the evening of the 29th and all day on the 30th, a group of people thinking about how social influences can sculpt intrinsic competitive motivational systems in ways that can really influence decision-making. So. please come if you're interested.
And someone said to me, how do you ever get deans to be interested in this stuff? Well, the vice chancellor for research is supporting that conference. So if you want to ask us how that's done, we'd be happy to share. Anything else?